I want to welcome everyone to this afternoon's session on how do you know stakeholders have an impact on research. This is an update to a session presented at the 2018 online KT conference sponsored by the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR. The Center on KTDRR is housed in the Austin, Texas office of American Institutes for Research, or AIR, and is supported through funding by NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research, which is a center within the Administration for Community Living of the Department of Health and Human Services. My name is Joanne Starks, and now I will introduce today's presenter, Dr. Thomas W. Concannon. Dr. Concannon is a senior policy researcher at the RAND Corporation, assistant professor of medicine at Tufts University School of Medicine, and Director of Stakeholder and Community Engagement Programs at the Tufts Clinical and Translational Science Institute. Dr. Concannon pursues two major research interests. First, delivery, access, and use of specialty care, including in burns, cardiovascular, and orthopedic health services. And second, involvement of patients, clinicians, and other stakeholders in health-related research. Dr. Concannon earned his PhD in health policy from Harvard University in 2006 and his MA in political science from McGill University in 1992. Stakeholder engagement is increasingly common in health research, with protocols for engaging multiple stakeholder groups becoming normative in patient-centered outcomes research. When designing a stakeholder engagement approach for a given research study, researchers need to decide which stakeholder groups to engage, at what study stages, and using what methods, given the resources available and the desired amount of stakeholder engagement. Today's presentation offers practical guidance for designing a multi-stakeholder engagement approach for a given project or study. Specifically, we present a sequence of questions to assist in selecting appropriate modes and methods of multi-stakeholder engagement for a given project. We introduce a matrix that study investigators can use to summarize their multi-stakeholder engagement approach, and we provide a list of further online resources. This guidance, accompanying matrix, and list of resources can assist researchers to consider more systematically which stakeholder groups to engage, in what way, and at what study stages. Dr. Concannon, are you ready to start?
Sure am, thanks. Okay. So thank you very much for that introduction. I'm very glad to be here to re-record this presentation, first given 2 years ago, and now with substantial updates based on work conducted over these past 2 years. So I really welcome the opportunity to be back here. As Joanne mentioned, the topic of this presentation is how we will know if the work we do with stakeholders in conducting research has an impact on the research. I have a few disclosures to make before starting. I do hold several research grants with not-for-profit organizations that do have links with industry. The first is the Pharma Foundation, that's the Pharmaceutical Research Manufacturers Association. Their nonprofit arm that's focused on research activities. I have this year with a colleague at RAND published a paper on engaging patients in health technology assessment that won an award in a competition sponsored by Pharma. And we subsequently obtained a grant to develop a repository of patient-centered outcomes measures or value measures. We have, on a related grant, are working with the Institute for Value Improvement, also a nonprofit organization with ties to industry, on engaging patients, clinicians, and other stakeholders in health technology assessment. And the majority of the work that I'll be presenting to you today comes from a contract that I hold with the Patient-Centered Outcomes Research Institute, or PCORI, which sponsors research that is stakeholder engaged and other patient-centered research. The work that I'm doing with them is specifically on evaluating that work over the past 10 years. These are a list of acronyms that I'll be using during the presentation. And for those of you watching online, you can access this list by downloading the PDF of this presentation and referring to it as I go through. Today's presentation has 4 parts, and thankfully the first 2 parts are really storytelling. I like to start off my work with some motivational stories. This first one comes from 1987 and is a story of substantial success around engaging patients. The second one is from 2009 and is a story of failure around engaging patients. And so we're going to get a look at engaging patients, stakeholders, and other stakeholders from both angles. And then really I want to talk to you about two pieces of this puzzle. How to go about planning an engagement activity in your research. And then once you've done that and perhaps have developed a substantial body of research over time, how you'd go back and take a look at whether engagement works or has produced your desired outcomes. And so the first story. I said this was from 1987. This is a photograph of Peter Staley from a movie called How to Survive a Plague. The photograph is from 1989. And he said about this photograph, this is only round 1, lower the price or we'll escalate. And so in-person presentations, I like to ask the audience if they recognize this, this person, this photograph, or what this is about. But since there is no audience, I'll just get to the punchline here. This is Peter Staley, one of the founding members of an organization called ACT UP, or the AIDS Coalition to Unleash Power. And I'll tell you a little bit more about ACT UP on the next slide, but what they said, this was immediately after the release of one of the first antiviral medications called AZT. And after this is obviously a person getting arrested. He was getting arrested at the headquarters of Burroughs Wellcome, which was the maker of AZT. And he said about the demonstration, after the demonstration, they, referring to Burroughs Wellcome, buckled and lowered the price by 20%. From then on, the industry said it's probably smarter to try and talk to activists and placate them as much as we can. The issue here was that AZT emerged on market with a price tag of $10,000 per year, which today seems like a modest or maybe even reasonable cost for a life-saving intervention, but at that time was really way outside of our experience paying paying prices for drugs. So ACT UP emerged in 1987. This is within the first decade of the pandemic. And in that decade, people living with HIV had already faced devastating illness. There were very high mortality rates with this condition. 31 people died of AIDS complications in 1981, and 18,447 by 1990. There was a perceived inaction of most policymakers around research and care of people living with HIV, and a perceived grindingly slow pace of research around the development of molecules that might help. So ACT UP was founded by patients to, quote unquote, take direct action to end the AIDS crisis. This is really unprecedented. This is an unprecedented form of activism that patients prior to this point were not historically known to organize around the care and research that they were receiving from the establishment, medical establishment. So this was really quite a very aggressive and direct form of demonstration and activism by the public, essentially, on a matter of medical concern. The members of ACT UP were really ambitious. They wanted to affect all matters of healthcare that were leading toward their care or research about their care. So no corner of healthcare was off limits to this group. They engaged with healthcare decision makers in government, in industry, in insurance, and in employment. And they became self-taught experts in drug development and markets, in virology, immunology, and biostatistics, and in regulatory affairs. And over time, they achieved dramatic change. So just in the first 10 years, starting off with this demonstration at Burroughs Wellcome, they had an impact on drug marketing and pricing. They worked with the National Institutes of Health and the Food and Drug Administration to accelerate drug development. They worked also with NIH and FDA on the development of alternatives to strict placebo controls in randomized controlled trials. They worked with NIH, an organization called the Agency for Healthcare Policy and Research, now known as AHRQ, or the Agency for Healthcare Research and Quality, on the development of something called community research initiatives, which essentially take the enrollment of patients into clinical trials out of academic medical centers and into community-based organizations. They worked with the Department of Health and Human Services on the development of the Ryan White Care Act in 1990 that substantially expanded healthcare delivery services for people living with HIV and AIDS. And they worked with the CDC, the Centers for Disease Control, and NIH on an updated definition of AIDS in 1993, more than 10 years after the start of the epidemic. The definition of AIDS was changed to become more consonant with the condition in women and injection drug users. And then by 1996, HIV treatment hit a home run. New multi-drug antiviral therapy was able to contain HIV, the virus that causes AIDS, was able to contain and stop the virus in its track. And now HIV is considered very much a chronic condition, a manageable chronic condition. And so what's the upstart? Is that ACT UP became part of the success story that culminated in the discovery, development, and rapid uptake of effective treatment for millions of people in the United States and across the globe. And so activism by people living with HIV and AIDS, the public, encouraged waves of patient-initiated engagement in healthcare and research. And we know of that now from patients living with breast cancer, survivors of the World Trade Center disaster, and other patient and public healthcare events that around which patient groups have formed to influence policy. But we know, those of us working in academic health centers and in university research and also in industry research, that we've been mostly shielded from patient activism. That is until around 10 years ago, as new funding for a type of research called comparative effectiveness research came about through the American Reinvestment and Recovery Act in 2009. And again, new funding came about in the Affordable Care Act of 2010 that required patient and other stakeholder engagement in the work that we do. It came with detailed guidance on what engagement means, what it is, and this was developed principally by the Patient-Centered Outcomes Research Institute, but since then has been developed by other agencies. And then PCORI, through its work, has been able to influence guidance on funding that comes from these other agencies, like the Agency for Healthcare Research and Quality, the National Institutes of Health, and other health and human services agencies that fund research. And around 2009, as this story was unfolding in academic medical centers, I had a colleague, another researcher, who said to me, being faced with a requirement by his funder to involve patients in the work that he was doing, he said, "This is hard and I don't know if it's worth it." And I thought to myself, geez, where have I heard that before? And I could look back on the start to my own career in 1992 as a patient advocate for people living with HIV. When we were being required in the care setting to involve patients with the virus in the governance of our organizations, so 25% of our board had to be seated by people living with HIV. And in the policymaking roles of the funder, there were important and built-in structures for patients to have decision-making authority. We went about in the 1990s learning about how to involve patients and the clinicians who care for patients and other stakeholders in that work. And I thought to myself, it really turned out not to be rocket science. And this may be something that I could help other researchers learn about. So I began writing about this around that time to help demystify the process of involving patients and other stakeholders. And so my question that motivates this talk is, if researchers could engage other patients and other stakeholders, would there be more success stories? So I want to return to the second story, and around this same time, in 2009, a second story that was really not such a success story. This is a person appearing on CNN nightly broadcast called Larry King Live, no longer on the air, but who said about this case, feedback about the recommendations makes it clear that we need to have better messages. And again, I often ask live audiences who this is and what she's talking about. And I'll just give away the punchline here. This is the vice chair of something called the United States Prevention Services Task Force, or USPSTF, on the widespread opposition that had evolved and emerged to recent mammography screening guidelines that had been released. This was in October 2009. A little bit about USPSTF. It includes in its work, USPSTF is a guidelines developer. It develops clinical guidelines that clinicians, doctors, nurses, and patients can use around making decisions as to whether a treatment is right for an individual patient. In developing these guidelines, the USPSTF does include experts and engages with some stakeholders. It is itself a 16 volunteer member board who are already experts in prevention, in evidence-based medicine, and in primary care, but principally drawn from the ranks of the research community. It partners with organizations such as medical societies, insurers, and consumer organizations before guideline development is underway. So that is all about identifying the next topic for guidelines. During priority setting for determining when to update the mammography guideline, insurers and consumer organizations and clinical societies weighed in and said, yep, now would be the time. Let's get updated guidelines on how to do mammography and when. And it also partners with organizations like these after the guidelines are completed to help with dissemination and implementation of the guidelines. But it does not engage with all stakeholders outside of the board during guideline development. If they do not have methodological expertise, this is a highly technical process of developing guidelines. And so patients don't have the appropriate methodological expertise to weigh in on the ins and outs of guideline development, systematic review, and all the inputs to that. or they are excluded if they have a perceived conflict of interest. And so this is industry, payers or insurers, employers, and certain subspecialties of medicine that might have a vested interest in the outcome of the guideline. And so who are these groups? If you look at them in parentheses, the patients, the industry groups, payers, employers, and subspecialties, who are these groups in the story of this mammography guideline? We'll come back to that in an upcoming slide. Just kind of put that on hold and think about that as I go through the next pieces of this. So I want to describe what this guideline actually said. So it was reissued again, and it was an update to an existing guideline. They conducted a systematic review of new clinical research on mammography screening, which on average showed that 15%, that it reduced breast cancer mortality on average by 15% in women ages 39 to 49, by about the same amount, 14% in women ages 50 to 59, and by a larger amount, or 32% in women ages 60 to 69. But the younger women, or the women in this youngest group, age 39 to 49, were more likely to have false positive diagnoses from mammography screening, leading to potential harms. So that's a very high level summary of the systematic review that was conducted. This is a summary of the guidelines that they developed from that review. The USPSTF recommended routine, biennial, or every 2-year mammography for women between the ages of 50 and 74. And so this is roughly 24 years of elapsed years in a person's lifetime. So biennial mammography in this period would amount to about 12 mammographies over the course of one woman's lifetime. And it also recommended that women younger than 50 get mammography only after considering their individual risk factors for cancer, breast cancer, and their own patient preferences, Would they like to know more than the average person would about potential development of nodes that might lead to breast cancer? And that that mammography should be available, but it should not be routinely offered in the primary care setting. It should be made available to women who have previously considered their individual risk factors and their own patient preferences, and together with their clinician decided that, yes, I would like to start mammography screening earlier than age 50. This should be available, but it should not be routine. Women of all ages should hold those discussions with their doctors about their risks for breast cancer and their preferences for screening. And so you can see how they meant for this screening guideline to be somewhat flexible, so that, that women, their doctors, are encouraged to talk about the risk for breast cancer and to develop an individualized plan. You would think, though, from the opposition that was unleashed when this guideline was released, that this second bullet was the only thing that was said, that mammography for women younger than 50 should not be routine. The release of the recommendations unleashed absolutely vehement opposition from radiologists, oncologists, patients, and advocacy groups. And again, who are these groups? This is the question I was asking earlier. These are exactly the groups that were excluded from guideline development. Go backwards here. So patients were excluded because they are not technically trained in the work of systematic review. Radiologists and oncologists were excluded because of their potential vested interest in the work of mammography. These groups said that the new guidelines would, quote unquote, turn back the clock on the war on breast cancer. They were able to get bipartisan legislation that guaranteed coverage of annual screening starting at age 35 and continuing through the end of life. So that takes it up from 12 mammographies in a person's lifetime to somewhere between 35 and more, maybe 40 mammographies. And to this day, many physicians and institutions resisted the guidelines and do not offer services based on those guidelines. So what a waste of money. What a waste of money. This huge investment in systematic review and major US attempt to change the way that mammography is delivered. They did not, that work did not substantially alter screening practices. So what are the lessons learned about working in research with patients, clinicians, and other stakeholders? Number one, engage with all stakeholders, excluding even patients because they're not trained, excluding even folks who have a financial vested interest in the outcomes of the research, that these exclusions can backfire. And you really should, this is the advice, you really should consider whether an exclusion might end up backfiring on you as a researcher. We recommend that you use a structured process to identify and recruit stakeholders, and I'm going to go through what that might look like in a few slides. We also recommend that all stakeholders, including patients, are experts on their own views. And this is the fallacy, this sort of goes to the fallacy of excluding patients because they're not experts in research. They are experts in their own views about the meaning of research and how they will use it in their own care, how they will bring it to their doctor, whether they will, whether they understand it, whether it could be messaged differently. They're experts on their views about research, and we should recognize that as researchers. And this is a valuable input to the work that we do. And that other stakeholders who have financial vested interests in the outcomes of the work we do, that their conflicts of interest can be managed by us. And it is no excuse to exclude industry and subspecialists from the work that we do. In fact, I would even argue that those of us working in academic medical centers, though those are nonprofit organizations, are plagued by conflicts of interest relative to the management of hospitals. A second major lesson that I take from these stories is that how you engage with patients, clinicians, and other stakeholders is important. All stakeholders should be prepared for engagement, including the research team or the team of researchers who will be conducting or managing the engagements. That ultimately the goal is, once prepared and once initially engaged, that stakeholders of different types with even competing views, sometimes conflicting views with each other, that they should be scheduled to meet on common ground in the same place at the same time to help you with your research. Because why? Because we as researchers want to see the canary in the gold mine come out or not come out. We want to see where the conflicts are and be able to avoid those conflicts before they erupt in our faces. So it is really important, in my view, to bring stakeholders with competing views to the table when advising us on research. In order to do this well, we have to sustain relationships with the different stakeholder communities over time. We typically work in an area of clinical research or health systems research over half a career, a full career, a decade, couple of decades. We have these relationships and we should be sustaining them with individual organizations, with representatives from those organizations, or with individual patients over time, and really give back to these communities that we work with over time. That we should call on experts to help us lead engagement activities with these groups, particularly if we are inviting folks in with conflicting views, views that conflict with each other. because we know we're treading on ground that might be plagued by conflicts of interest, by conflicts between stakeholder groups, that we should choose the modes and methods by which we engage stakeholder communities very carefully. And that we should get advice from experts, that even if we don't have the funding to get expert leaders for focus groups and for advisory group meetings, or for whatever it is, technical expert panels, even if we don't have the funding for that, that we can consult with experts in our own research institutions. The experts are proliferating everywhere. We should also recognize that engagement work is like any other activity in research, whether it's recruiting patients for involvement or participation in a trial, or managing a research budget, or managing research data, or interacting with the IRB. That engagement is another activity in research, that doing it right is no guarantee that it will be successful. You can do everything right and you can still face insurmountable barriers to getting it right. That it may require trade-offs with other goals of research. And because this is true, that we should be very cautious about over-promising engagement activities. It's very important that we scale engagement activities to the needs of the research agenda. And so here, that's a segue into the next topic, how we go about planning an engagement activity. The first step to planning an engagement activity is to understand why we're engaging in the first place. The second step, to identify whom it is we'll be engaging with. The third is to figure out how we will do the engagement work. And then the fourth and final step is to sketch out the research activities in which the stakeholder groups will be engaged. And these are a list of acronyms that I've pulled together, and names of engagement styles that I've pulled together. All of these acronyms and names involve some notion of working with stakeholder communities. And I just pulled together a handful off the top of my head and kind of stacked them up here because, you know, for the person who is coming to this field for the first time, or is maybe an experienced researcher and knows how to get research grants, or a person who is experienced at getting publications in press, this is a whole lot of Tower of Babel. I mean, that, you know, like we hear action research, emancipatory research, stakeholder engagement. I've wondered, and I don't think it's any surprise that many of the folks I've spoken with wonder whether this is really something meaningful or not. And what I've done here is I've highlighted 4 of these traditions that I think do promote something really important around engagement work. And I'm going to talk about those a little bit more. And so for this first topic, understanding why it is we're doing the engagement work in the first place. I break down the reasons for engagement into 2 large buckets. First, the intrinsic goods that we get out of engagement. And goods that are intrinsic to engagement work are the kinds of things that go to the relationships between researchers and stakeholders. By engaging, it's sort of just intrinsically an outcome that we build accountability for the research, or we build trust in the relationship, or we empower the stakeholder community. It's just an intrinsic outcome of relationship building. And one way of talking about this whole body of goods, these are 3 examples: accountability, trust, empowerment. There are many, many others that fall into this intrinsic bucket. But one way of talking about this is to say that we partner with stakeholders just because it's the right thing to do. There's a whole separate and complementary set of goods that we might think about pursuing. And these are the instrumental goods that we think we might be getting from engagement work. And these are the goods that are not, say, intrinsic to the relationship, but are maybe a product of the engagement work over time, that we hope the research questions we ask might be more relevant to the groups that we're working with. that the groups we're working with might understand how we conducted the research and what it means over a long period of time, that the research evidence we produce itself might be more useful to these groups. And so a way of talking about this is to say that we involve stakeholder communities because just doing so makes evidence better. It makes our work better. Two of the approaches that I named on that Tower of Babel, stakeholder engagement and broadly engaged team science, share some key items, some key, let's say, factors or features that I would like to talk about. These are, again, they're terms. They're used differently by different research groups, and that's why I've drawn out this Venn diagram. I don't think these are exactly identical terms, but I think they do overlap on a couple of key items. And these are, they ask for us to tailor the engagement work that we're doing to the research objectives, scale it. If the budget for research is not very large, if the objectives are very limited, we want to plan a limited engagement activity. If we have a large budget, if it's over time, we want to potentially scale that up. It asks us all to also to identify partners who are important in the future use of the research evidence we're trying to produce. So there's a really link between the people we bring to the table and the hopes that we have that the research itself will be taken up and used. It asks, these paradigms ask us to plan engagements, I said this before, that are within budget, but also respectful of partners' capacities. And I don't mean capabilities, I mean capacities. We have to recognize that when we bring patients to the table and ask them to work with us, that they are often parents or they're students or they're workers, they're folks with jobs. They have lives outside of the work we're asking them to do with us, even if we're paying them a stipend. They have lives, and they've, in speaking with patient communities, representatives of patient communities and so on, I've heard over and over that the thing folks want to know most is what was my how did my contribution help the research? So absolutely, item number one is that especially patient groups want to be communicated with over time and really carefully and in some detail about the work that they've contributed. These traditions also ask us to design engagement activities that maximize research outcomes. And what do I mean by this? So we want to focus the engagement work where the research can most benefit. So where is it that bringing patient and clinicians and other stakeholder representatives into the work can really help us? Is it in defining the research questions? Should we involve these folks in defining the outcomes that we'll measure in the research project? Should we work with these folks to collect data, interpret data, or should they be involved in implementing some aspect of the findings in practice settings after we're done? The second major step is to figure out with whom we're going to be engaging. And this really should be done systematically. And to start with this, we might think about who we mean by stakeholder. What does this term mean? A really popular and widely used definition of stakeholder has been over decades that a stakeholder is any individual who has the potential to take interest in the work of researchers or the work that we do. And these are the paradigms that have called on this kind of stakeholder definition. Social movements, action research, community-based participatory research. This definition of stakeholders or communities really focuses on members of a community in a defined geographic area. These are folks who might take an interest in the work of an academic research institution. They are individuals who live in a community or in a province or in a state or in a nation, defined again geographically. A new and emerging kind of notion about who stakeholders are is a definition where we say that a stakeholder is an individual organization that is responsible for or affected by decisions that may be informed by research evidence. This is absolutely critical. The turn here is that we're moving away from just mere interest to those who make decisions that we're trying to help inform. So our product is research evidence. The work we're trying to inform is decision making. This defines stakeholders as this kind of definition is used in frameworks for engagement developed by science policy. In research reform, I mentioned in 2009, the Affordable Care Act brought forward this notion of stakeholder engagement. And it, again, focuses on decision makers and those affected by decisions. And so it points us as researchers to the end users of our products, research evidence. I worked with a group of 25 individuals, 9 co-authors and 15 stakeholders on the development of a framework that could help us identify systematically who stakeholders are using this definition. And we came up with a mnemonic called the 7 Ps. This identifies 7 key groups that we recommend that researchers should consider when designing involvements in health research. And the most important thing to remember about this is that it is a mnemonic, it's a tool. It is not a recommendation that there are exactly 7 stakeholders for every health problem. It does not say that you shouldn't break any one of these groups into multiple finer categories. We really recommend that you do. And for that reason, we gave detailed descriptions of the kinds of subgroups that do fit within these 7 groups. We recommend that each time a research topic is taken up, that researchers scan through these 7 categories and these lengthier descriptions to think about who the decision makers are they're trying to inform, and who are the individuals and organizations who might be affected by those decisions. And just to be clear, though I was involved in writing that 7 Ps model, I have no pride of ownership or authorship over this notion, this definition of stakeholders. And I sort of later did a comparison of the 7 Ps model to 2 other frameworks for identifying stakeholder communities, one known as the PCORI model, or the Patient-Centered Outcomes Research Model, which identifies 9 stakeholder communities, and the Center for Medical Technology and Policy model, a group in Baltimore, developed their model the same month and year as I developed the 7 Ps model. And they identified, I think, 8 communities, if I count them here. And this chart is a comparison line by line to show that these 3 models with 7, 9, and 8 communities merely slice up the same pie in a different number of slices, that they're really one for one, pretty well matched by community group. It doesn't matter. The upshot here is that it doesn't matter which of these models you take and use. I have quite often opted to use the PCORI model and really set aside my own when I thought that was a better pitch for the client. The next step in defining who your stakeholder communities are is to ask yourself 4 questions. Question number 1, what decisions are you trying to inform with evidence? Question 2 is which stakeholders make those decisions? 3, which stakeholder groups are affected by those decisions? And we'll go through this in a little bit more detail. And then how can engagement, if you were to engage with any of the communities you've identified, how could engagement potentially improve your research or the evidence it produces? So the first step is to describe the health-related decisions you mean to inform. So if you're working on the comparison of one drug to another that are out on market, you might be you might think of the patients who use the drug or the clinicians who prescribe the drug as the prime decision makers you're trying to inform. That's just an example. And then the next two questions. To identify the stakeholder groups first who make those decisions. So I just talked about an example where you might identify certain patients who might be decision makers or clinicians who might be decision makers. And to use a chart like this where you can sort of jot down some notes about the specific types of patients you're interested in. I left some lines here to fill in, and the kinds of decisions they make. And to just go down this list and see if you're trying to inform one community, one of these 7 Ps, 2, 3, or 4. It's not necessary to identify a decision maker in every one of these, but to really focus in on the prime decision maker that you're trying to inform with evidence in the research project. Invariably, that's going to enable you to move on to the next column and the third question. Which stakeholder groups are affected by those decisions? So if, for instance, patients and providers are choosing between one drug and another, the groups that are affected by those are the insurers or the payers who will pay for that drug. If one of the drugs is much more expensive, say, the payers are a community of decision makers who are, affected and will have to make determinations on whether the drug is covered. Similarly, purchasers or the employers who purchase insurance premiums may be affected by increased premiums if a whole bunch of expensive new drugs come out in 2020. Premiums will rise and purchasers then become an important affected community. Policymakers who regulate drugs might be an affected community. Product makers who make the drugs might be an affected community. If one drug sort of performs better than the other, the company that makes that drug is bound to benefit, and the companies that make a competing drug are bound to lose. We do not recommend that you bring in the specific representatives of companies that are making products that you're evaluating, if that's what you're doing. But having representatives of the industry can be helpful. Principal investigators are often affected by evidence in the sense that they will hopefully cite the evidence and use it in future research. The third step here is to identify target numbers in each of these groups. So if you have enumerated, say, six different patient types or 3 different provider types, hospitals and doctors and nurses and so on, how many individuals should you bring on into the stakeholder engagement effort? And sort of sketch that out. This will help you with budgeting the activity. And only after you have done all of this work to sort of sketch out who the personae are, the types of individuals and organizations that you want to involve in and what numbers, only then begin to identify the names of individuals. The reason why you hold off on identifying names is that if you start out there, the likelihood is that you're going to go to the usual suspects. Who do we know? Who has expressed interest in this? And then you're just eliding or sliding back into that old definition of stakeholder, of folks with an interest in the research. We hope that you'll be more systematic about identifying decision makers. Step 3 in planning engagements is to figure out how you're going to engage. And I mean something very specific about this. This is a diagram that I adapted from colleagues in the United Kingdom who described engagement activities in 4 levels of intensity, starting with the lowest level of intensity, communication, moving up a ladder to a next step called consultation or advisory roles, up the ladder to the next step in which stakeholders become collaborators in research, And then finally up to the fourth and final step, in which stakeholders who we partner with become co-producers or even sometimes co-authors of the research that we produce. This group had recommended, I should say, by the way, this is derivative of a classic paper by Sherry Arnstein from 1969 that identified 8 steps in the ladder of participation, but it's a simplified model of that. And the implicit recommendation is that as you go up this ladder of intensity, that you're increasing the volume of engagement activity and potentially increasing the benefit to the research of the engagement activity. But what this diagram does not say, and this is very important, we've been advising on this since I started this work, is that as you go up this ladder of intensity, you're doing 2 things. You're consuming on the y-axis or the vertical axis more of your research budget. And we recommend very carefully that researchers and stakeholder partners be judicious about the use of research resources. These are public resources and we have to be judicious with them. When we consume more of our budget in stakeholder engagement work, we take away budget from other parts of the research, and we want the research to be successful. We want it to get to publication and use in clinical work. And therefore, we want it to be scaled, to be balanced with all the activities of research. So we recognize that as we go up this ladder of intensity, we're consuming more research resources. But we also have to recognize that as we go up this ladder of intensity, we're demanding more time from the volunteers or the people we hire with stipends, not on salary, but with stipends. We're demanding more of their time and effort. And really to the patients and the volunteers who come from industry or from insurers or from policymaking groups, they want to know that their inputs, for every hour that they're engaged, that there's going to be a value that comes out of that. And so for that reason, I recommend that researchers make a very strong case as to why co-production might be needed. So whereas other groups are promoting co-production as the gold standard for research engagements, I am asking researchers to really consider carefully how you can use these lower levels of intensity to great effect and to great benefit. So I've said before, we can do a lot. We can do a lot with the patients we bring into our work by just doing a better job communicating with them, by just sharing the results of the research, by showing that we care, that they understand, by translating everything into plain language. Communication is really the basis of all of this. If we don't communicate well, we don't get anywhere. And we can then do a lot with consultation, a bi-directional relationship where we bring stakeholders in to help us and advise us at key points in the research process. Everything does not have to be co-production. And I just want to go to an example. I've thought about this for some time, and I had an inkling that industry, which is also on an engagement kick in its research, in the development of new drugs and devices that go to marketplace. Big pharmaceutical companies are now increasingly engaging with patients and patient representative groups because they know that they'll get value out of it. And I had an inkling that they were not promoting co-produced research or even collaborative research with the groups they're partnering with. And I just wanted to see what I would get from a Google search by looking at the consulting firm McKinsey, whom I know consults with the Pharmaceutical Research Manufacturers Association. So I typed in McKinsey, pharma, and engagement, and looked at the first page of hit results, and there were several McKinsey reports, and they were how pharma companies can better understand patients. This isn't even bidirectional or even communicating with them. It's just understanding, just developing relationships. The new world of patient engagement, which I will tell you was all about communicating. A 360-degree approach to patient adherence, which is all about getting patients into trials and keeping them there. It's not about co-producing with the trial research with patients. Pharma Medical Affairs 2020 and beyond, how we can involve patients in policymaking. Being patient-centric in a digitizing world, just sort of more understanding of patient lived experience. And from product consumer experience, the new way to launch in pharma. None of these reports spoke in any way about collaborating or co-producing research with patients. And the implicit lesson here is that an industry with a boatload of money to do this in any way they want understands that the biggest bang for the buck is going to be better communication, better relationships, and building sustained relationships over time. And I think that academic researchers, when we promote co-produced research, are really shooting ourselves in the foot. We're really setting forth a gold standard that few researchers, few budgets can really attain. And this leads me to the last topic for the talk, and that is this part of the talk. I should sort of figuring out what activities you will engage in. So for this, I'm going to go back to a definition of engagement that was developed by folks at PCORI and spoke about the meaningful involvement of patients, caregivers, clinicians, and other healthcare stakeholders throughout the entire research process, from planning a study, this is from the very beginning stages, and establishing the research question throughout the project, during the project, conducting the study, and after the project, disseminating results. What's meaningful about the engagement here is the involvement all the way through at every step. And so in a recent publication, I and this time 20 partners, so we had 10 stakeholder representatives and 10 co-authors on a paper in 2019 that set forth a matrix that would help us map out stakeholder engagement activities across 20 generically stated research activities. These are meant to be exemplar activities in 3 stages: preparing for research, conducting research, and then using research. All of that arrayed in the rows of this matrix. And then in the columns of the matrix, the 7 Ps. And what I've done here is shown an example of an engagement plan for one research project in which there were 3 steps. During the initial stages of conducting the research, the research team decides to consult with a multi-stakeholder panel comprised of 5 of the 7 community members. Later, it decides to collaborate a higher level of intensity with patients and clinicians. That red dot should be on the 3rd level of intensity on the ladder there. And then finally, just as the work is concluding and going into publication, to co-produce with members of the panel, 6 of the 7 members. And so this is more or less implying that this research team decided it could co-author its publication with 6 of 7 community stakeholder groups. And again, I ask audiences to comment on what's missing here, and I'll go straight to the punchline. What's missing is there was no work in this study to prepare stakeholders and researchers to work together. And so this group went back to the drawing board and added 2. As they sketched this out, they saw this gap. And before they submitted their grant, this is hypothetical, of course, they went back to the drawing board and decided to sketch in a training program so that patients could be fully ready when the study got up and running to be effective members of the engagement team. And then train researchers so that they become fully ready to work with stakeholders and really understand the different needs of different stakeholder groups. This is the final step in the talk. And this is really the crown of all of this work. And we, I should say, are just getting around to developing plans and guidances for this. And this is how we'll evaluate engagement work, how we'll know if engagement is having its intended impact And I should say, this really is just getting underway. The grant that I mentioned at the very beginning of this in my disclosures with PCORI is a roughly $1 million contract to work with PCORI over a 16-month period to help identify the types of measures that we might use to evaluate the impacts of engagement work. And I think there are 3 dimensions of impact, and this is not really that unusual, that they follow along kind of a routine and standard evaluation matrix where we identify the content we're evaluating, the process of activities that we're looking at. And here we're talking about the process of engagement, so adherence to principles of patient-centeredness, engagement, and translation of research to end users. And then on the outcomes on stakeholders, on research, and on the research itself, on researchers, and then on the research itself. So the first dimension, the content, is an inventory evaluation. It's sort of assessing what it is we did in the engagement work. And so here we might identify, first of all, I want to say on the left column of this slide, I've identified who are the types of entities that might use an inventory evaluation and why they might use it. And then on the right column, I've identified the types of things we might think about measuring. And so in an inventory of evaluation engagement work, an inventory evaluation of engagement work, we might report out the topics of research in which we engaged stakeholders, what types of evidence we were producing, whether it was trial evidence or systematic review evidence, or some other type of evidence that we were seeking to develop. In what research activities, if you remember the matrix I just showed, the 20 research activities are named generic activities, and which one of those did we involve folks in? Which stakeholder communities, what types of stakeholders? Was it patients? Was it patients and clinicians? Was it more than those 2 groups? And then what were the engagement activities? Did we convene meetings? Did we have them on email chats, or did we have them consult with us or co-author a publication with us? What is it that we did with these groups? And so that's what we might report just on the content. And this gives us context by which we can sort of slice and dice the rest of the evaluation. So those are the types of things we might measure. And I mentioned types of evidence, research activities, types of stakeholders, and then engagement roles and modes. And I have listed here in blue font, the types of frameworks that you might go to. These are published frameworks, and they're just notations on these frameworks. So come to this slide and use Google to retype these words into Google, and you'll find these frameworks online. I'm just going to pick out one of these. Under research activities, the Prisma Checklist it stands for Preferred Reporting Items for Systematic Reviews and Meta-Analyses. And this is a checklist of items that you might use in a systematic review to conduct the systematic review over time. Well, that is a handy checklist of research activities that you could use to report an inventory of engagement if your engagement work was on a systematic review. So I want to move on to the procedural evaluation. A procedural evaluation examines whether standards that we hold for the work that we're doing were met. And the folks who might use this kind of evaluation are research funders, educators, patients and the public whom we engage, and other stakeholders. And they might do this to examine the way the work has been carried out, and identify and spread approaches that work, and just sort of figure out whether we're meeting our own expectations of how this unfolds. And so, a couple of topics we might think about measuring. Did researchers set forth the rationale for engaging? Did they really get clear about why they're doing it? Did they set forth appropriate definitions of the stakeholder communities they will be working with? Did they think through all of the research activities? And I say extensivity here, it's the extent of engagement across preparing for, conducting, and using research evidence. Did they think about and then report on the intensity of engagement, the 4 C's: communication, consultation, collaboration, and co-production? Did they report on that? Did they meet their own standards? And then did they meet standards for the modes of engagement? If they set forth that they're going to hold, say, focus groups, were the focus groups held? Did they have any problems with enrollment in the groups or reporting out the results? And here is a list, again, of potential measures that belong to those types of, those areas of measurement. And so around the rationale, I'm just going to, again, highlight 2 of these, and you can refer back to this slide. Did the researchers set forth a rationale that spoke to the relationships that they'll be building with the stakeholder communities? Did they articulate the rationale in the terms of it's the right thing to do? Or did they focus on the impacts of the engagement work on research? Do they think that the engagement work might make research better? Or did they articulate both of these things? And what this does is it helps, identifying this procedural measure is, it helps us anchor the evaluation in the intention by which the engagement was set forth. And I'm going to go on to 2 final types of evaluations. And one of these are 2 evaluations of the impacts of engagement. And one of these assesses intrinsic aims. And again, I've set forth who might use this information and why they might use it. And then I've outlined a list of the types of topics that might be measured here. These are the intrinsic aims that go to the relationship between stakeholders and researchers. Did the engagement work improve or increase the autonomy, dignity, equity, and inclusiveness of different patient communities? Did patient communities feel that they co-own the work or did effectively participate in it? Was trust between stakeholder groups and researchers improved? Did science literacy improve among stakeholder groups? Just impacts on stakeholders. And here I'm leaving a whole blank page of the types of outcome measures that we might use here. And the reason I've left this blank is that it's the subject of the work that I'm doing currently with PCORI. And I know that there is very little out there on this. Folks have reported a variety of things, but there's been no systematic development or use of measures. And we hope to change this going forward. And a second type of outcomes or impact evaluation might assess the instrumental aims. And again, I've identified who might use this information and how or why they might use it. And under the types of instrumental aims that you might measure, you might look at whether aspects of the research design were changed to meet the decisional needs of researchers, of stakeholders. In other words, the research became more relevant to them. You might similarly evaluate the transparency of the work to stakeholder communities and the usefulness of the work to stakeholder communities. And then here, I've outlined a handful of potential outcome measures that you might use to evaluate these 3 categories. But again, this is really formative and not in any way a systematic listing of the potential outcome measures. And so that's the end of my talk. If this were live, I would love to take questions, but I know that a couple of questions have been prepared for me by the team recording the talk. So I'll pause here.
Well, thank you very much, Dr. Concannon. That was really interesting considering I had seen your presentation a couple of years ago. I really appreciate what you've added to it now, and I found it really engaging for the entire time to listen again. So here's our first question for you. Does stakeholder engagement equate to integrated knowledge translation, the process of integrating knowledge translation activities at the front end of a project, as opposed to waiting till the end of the project to think about strategies for incorporating knowledge translation?
Not exactly equate, but again, if I would draw a Venn diagram to show in what ways stakeholder engagement and knowledge translation overlap, they're clearly doing different things, or they're doing related things, and it might be that they overlap quite a great deal. But that's a question that, honestly, I would love to explore some more. I will say about that there is a recent paper. And I'm gonna forget the author's names, but it was a paper that explored the notion of design for dissemination, or DFD, I think it is, design for dissemination. And the notion there is that we design research and research engagement activities around the need to disseminate the evidence and make sure that it gets used in practice. And so very much links up those two concepts. But I think they're, the short answer is I think they are related and overlapping.
Well, thank you very much. A second question we have is, can you discuss how consumers and other stakeholders can position themselves to work more effectively with researchers and practitioners?
Absolutely. Well, number one, it's really a two-way street in which researchers and consumers and other stakeholders are seeking to develop relationships over time. And so to just get started, if I, as a consumer, I'm interested in a particular condition that someone in my family or I have, I could go about, first seeking out some training on research, and there are lots of research institutions that are offering trainings on engaging in research and helping with it. And so seeking out one of those to just get some familiarity with the types of research that I might be involved with, and then find the folks that are doing that kind of work by contacting really almost any researcher by referral. You might be able to develop relationships with the right folks. If you have those relationships and you're seeking to get started, an absolutely important and critical first step is to think through how it is you would like to be engaged. Do you want to be engaged on a weekly basis, on a monthly basis, on a yearly basis? Do you want to receive newsletters, in other words, receive information and communication? Or do you want to be more involved? Maybe participate on an advisory panel, or if you're a writer, maybe you would like to write memos on a certain topic for a research team from the patient perspective. Think about the ways in which you would like to be engaged, and think about them from the standpoint of how much time you would like to give, what kinds of energy you have to give, and so on. And if you were able to really come to a research team and help them understand how you want to be engaged, that would really go a long way to forming and developing the relationships.
Well, thank you very much. I really do appreciate your presentation this afternoon, and I want to thank you. And also I want to thank Shoshana Rabinovsky for helping with logistics, and Neidler for supporting the activities of the Center on KTDRR. Thanks again, and I hope you all have a very good afternoon.
Thank you for having me.